All right. Well, nice to have a different perspective here. You can tell that, first off, a couple differences. This isn't done at the end of the session. And I have a different panel. A panel who I usually talk about what's happening today, and I think, as you'll see from this panel, they're really looking at what's happening in the next 3 to 5 years. And I think that's what I'm going to be challenging all of you on. Probably don't need to do any introductions, but I have Michael Kaschke, our chairman at Zeiss. You just know and met Ashley. Do I call you Dr. Pyott now? Because you have an honorary degree, I believe, right? But David Pyott, ex-chairman at Allergan, and then obviously Dr. Peter McDonnell, who leads the top leading institution. Fellow Allergan board member, too, if I'm correct, right there, Peter, from that perspective. So really a tremendous perspective of what's happening in our industry. But before I do that, I wanted to just tee up a couple slides which will lead us into several questions. So what you can see here is these are things that are impacting us today, but what I'm going to challenge this group on is they're going to really be much more impactful to all of us in the near future, every one of these topics, and I'm going to delve into these. But I guess the one that I really want to talk about is how much is the consumer influencing this change? And I think we have much more engaged consumers today. I think everyone in this audience understands that the consumer, no matter if you're on the industry side or the practitioner side, the consumer is much more involved in their healthcare decisions. And digital technologies are actually allowing them to have much more access. And I'll show you a couple facts in a minute. But you know, everything from those fitness devices to wearable technologies, they're involved, they want to be involved, and they're going to be much more demanding on companies as well as physicians. So the challenge here is, what is the reality of all this? We talk about these type of technologies, but where are they? Are they here today? Are the patients being much more involved from that perspective? And you can see that there's an exponential increase overall in each of these areas. And in fact, I think the phrase is, you can't say we're going digital anymore. We are digital. Now, what does that mean? You know, that's a big term, and that's what I'm going to challenge this group about. But I just did a little math. There's over $30 billion today invested in digital health since 2013, $30 billion. If you do the normal multiples that a lot of you do in the room on your businesses, and assuming that you got to have about a 4x return over 10 years, you're talking $120 billion in the next 4 to 6 years. So team, get ready. Tell me about how that's going to be addressed, and we'll get to that in a second. If you go to a couple other quick slides before I bring the group up, interesting slide on the left here. Since 2015, probably a slide I'm not sure if you would all realize that, but there is a steady increase in virtual visits and a decline in physical office visits. Now, I'm not sure if everybody would have understood that, but you could see that that change is happening. So as again, it's not will digital be there, digital is there. And from that perspective, there's both society and cultural issues that are impacting that and how companies interact with that. And then of course, regulatory compliance from a standpoint of cybersecurity initiatives. What does that mean now that data is floating in the air there, and what challenges does that mean for companies? So I leave you with the last slide. Why does the future of healthcare really matter? Interesting, and again, what my 40th Academy today, for my 40th Academy, and what gets me still excited is that every day great physicians and great companies are impacting somebody's vision. That's unbelievable, and that's really a chilling effect that I thoroughly enjoy and why I'm here. But you could see here that statistics have shown that we have 97 million premature deaths by 2030, 97 million. And a healthier world will cost us about $371 billion by 2030. So investing in a stronger healthcare system comes with a price, and the price is, how do we impact that? How do we become more educated, and how does the consumer become more involved? So I'm going to challenge this group with several questions on my remaining time here, and then how are you all strategically planning for the next decade of healthcare? And again, I thank these four individuals to taking their time out of their busy schedules to come with us from that perspective. So, I don't want you to get your free T-shirt yet. So if you can go back a slide, you get your free T-shirt at the end. So, Michael, let me ask you the first question. How do you see the revolution in digital medicine changing, or will it change the fundamental job of a doctor and a surgeon?
First, I think as you stated, the digitalization in healthcare is already there, so it's not something to come. Yes, it will change the way healthcare is practiced. The fundamental job of a doctor and then interfacing with a patient, I do not think will change, but how this interface is going to happen will change. I take the digitalization is a big buzzword, and my principle always has been the bigger the buzzword, the more you have to break it down. And I simply break it down into two pieces. Digitalization will mean, and sorry to be that open, industrialization of healthcare. The healthcare industry is still way behind a lot of other industries. So what digitalization will do, it will make the industry more efficient. There's no way around it. And the second, it will bring us kind of democracy into the healthcare system, essentially by higher patient education, an ability of every person on that planet Earth to interface with a healthcare institution, with a healthcare provider, and to get an understanding and a better understanding about his or her health. And these are basically the two effects which will fundamentally change healthcare, in my opinion.
Okay, thank you. David, what extent should medical companies interact with these new players, i.e. Google, et cetera?
Yeah, well, as always, I sort of start with who's the audience. Many small companies here, and I think my advice would be probably do a lot of reading and a lot of watching if you're a small organization, and especially watch what some of the larger ones, such as a J&J, are doing. What are their experiences? Another good one would be, say, IBM Health and Watson, which they invested a lot in. I would say it's kind of realized now that some of the promise just wasn't there, and that's been not abandoned, but adjusted back. So I think very clearly anybody in this industry cannot ignore potential cooperation with the tech majors. What will their impact be? Huge opportunities, but also, as always, risks. So if you are getting into a partnership, a collaboration with one of the tech majors, I would think about it very carefully in terms of what do they bring to the party, what does one's own organization bring. My recent sort of major learnings actually is serving on the board of Philips in the Netherlands, and happily they're a consumer electronics company when you kind of dig under their DNA. So you can imagine a lot of interest for both Philips as well as Google, Microsoft, etc., to work with us. And I think the real thing will be domain experience. And within that, of course, bringing this knowledge will finally come down to the real issue, as always, who controls the IP? You know, how do you, if you like, share the benefits of whatever is being produced by better, often visualization of medical conditions or allocation of priorities within the care environment?
Peter, you've had a unique experience, as I said. I've known you for many years. You're obviously a leader from a physician standpoint. You run a major teaching institution, and you were on the board of Allergan. How's the interaction going to occur between industry and physicians to do what we're hearing and what I showed?
Well, you know, we talk about the valley of death, and certainly I think a decade ago, a lot of promising ideas just did disappear. Something exciting happened in the laboratory, and the scientist or the researcher didn't have a way to get with industry and get that idea socialized and hopefully converted into an R&D project. So what's happened now, and you see, I think, a lot with the presentations here, is startups happening. My department, 14 startups out of my small ophthalmology department. Last 5 years, 14 companies started. But in addition, we have big collaborations with Bayer and other pharmaceutical. So we're agnostic into how discoveries from the lab get to the preclinical and clinical stage R&D programs, but we're really eager to see that we, rather than have interesting research projects get published in prestigious journals, they actually make the transition to where they're touching the patient. And universities in this country, I think, a long time ago weren't great at reaching out to industry and forging strong working relationships. And I think now it's a lot better. I think in my career, dramatic improvement in that collaboration.
Ashley, when Bill was talking to you and knowing our interactions and talking to Alex, high tech and digital. So you have a high tech business. How do the two marry? How do those two work out going forward?
Yeah, no, I would, I guess a couple things. It's helpful when you see different industries. I would actually concur that, healthcare is probably on the S curve here relative to what's happened in the financial industry or how commerce is conducted, or even in cars. Like, look at all the sensors in our cars. So for us, that kind of excites us because it lets us know, wow, the best is probably yet ahead. And again, the nature of our business is, helping patients around the world. So if we can bring the best of that to bear, good things will happen. I guess I break it down to maybe some simple examples, Jim. I was in a case on Monday at Children's Hospital, Pennsylvania, for a cranial maxillofacial deformity case, and with one of, a very experienced surgeon. And so how has digitization changed how care is delivered? I'll give you an example. One is we had a remote virtual pre-planning session with a leader who was an engineer who wasn't in the room. We took it from a static x-ray to a 3D plane to see all of the different planes of a 12-year-old boy. That enabled us to cut down the anesthesia time in half. We were able to create a custom implant for this 12-year-old boy. And quite frankly, the precision of perfection, enabled him to not have to do a revision. And so for me, that's just a really good use case of how technology can really help enable patient care.
So Michael and Ashley, let me build on this. We're getting a lot of data interchange. Who owns the data? Michael?
I think that's an ill-posed question. For me, because it's
I'm
clear
in trouble now. But okay, I'm in trouble now.
Because it's clear for me, the patient, when you're talking about patient data, the owner of the data of a patient is the patient. There is, for me, no way around it. And the question is, how do we organize the access and the utilization of this data? And that's why this entire talk about who owns the data, in my opinion, is not really helping. We take, as a company, this very simple principle: patient data are in the ownership of the patient and should remain there. And then it's a question, how do you organize the access? How do you make transparent to what kind of use you want to take these data? And this is what we should be talking about. And I think that is a difference that the medical technology industry can bring into the digitalization compared to the consumer platform companies that we see around and that we somewhat incorrectly call high-tech, as there must be on this panel too. For me, this is a different technology, and I really would say, and we really would call the audience here to make sure that we take a stand that the ownership of patient data remain with the patient, and we organize the industry accordingly.
Ashley? No.
No, I think I actually concur. I think you have to get out of that debate and get off a go. And a couple things. One is, I think we have to figure out a little bit more of the regulatory pathways when you start to bring in machine learning into interoperatively, having kind of an augmented surgery. What's the role of the surgeon making decision making if the algorithm told them to do something different? So that is a little bit of the gray zone that we're going to have to figure out together, because we ultimately think patients will benefit from that. And you can anonymize data right now, and we're doing it all the time, working with hospital systems to make cases more predictable, less variable. And so I think we're already kind of over that.
So David and Peter, are the patients, doctors, and industry well prepared for this technological development that we're talking about and seeing? Are all three aligned, David?
Well, I think whenever there's momentous change, organizations, people, all of us kind of struggle. It's kind of like something scary. You know, my thing's mountain climbing. So, you know, if you go up a really steep ridge in really bad weather, you're kind of a little bit nervous. And if you make it to the top, and even more important, make it down, you know, you're really happy. So I think that's the feeling. So how does an organization tackle that? And I think, like always, you need to introduce some foreign bodies into your world. You know, people who don't come from the same experience set, people who come from maybe the tech majors, or especially people running hospital healthcare systems that understand, as this change is executed, what does that mean? So I think that's the way you set up a learning environment. And I think at the beginning, like always with something new, I always advocate choose something that's very tangible where you think you can have a quick win. And, you know, I'll give you a good example within Philips because of all the equipment they have. You know, they're leaders in pathology, and I've never been in that business before. But you can imagine it's almost shocking to learn that when a group of 6 or 7 people go through cases, they have about 30 seconds to decide what is going to happen to that individual patient. Now, of course, you can imagine you need a triage. There's some where there'll be a lot longer time spent, and the benefits of machine learning, where the machine has already sifted out the obvious ones, i.e. no problem over in this heap, and we all know it's the problem cases where you should be spending 80% of your time. Right. So that's the way I think about it, is introducing the right kind of different thinking from outside and coalesce it.
Peter?
I agree with David's comments. The head of telemedicine at Hopkins is an ophthalmologist, has been running it, and we've been learning interesting things. When my colleague, the head chair of neurosurgery, gets a CT sent to him, and he tells from a patient what can we do, and he gives some advice, what he thinks, and then the general counsel at Hopkins says, that didn't come from outside the state of Maryland, did it? Because if it did, you just broke the law by practicing medicine across the state line. So we're trying to work with people in DC and inform regulators, because our belief is if it's the right thing for the patient, if it's good for the patient, then it's a good thing. But we deal with all these rules from back when medicine was different, you know, and we weren't all connected. And people want us to help them, and they don't care what state they're in. And we want to do that and respond quickly. So definitely it's a learning process, trying to do the right thing, encryption, protecting patient data, making sure it can't get misused. But we've got to develop these protocols rapidly, because particularly the younger patients have a different expectation when it comes to responsiveness.
So Peter and Michael, I'm going to let you keep going here, Peter, and then to Michael. Tell me about what's going to change over the next 3 to 5 years between the patient and the doctor relationship.
This generation of doctors is much less likely than my generation to start a new practice. They want to be employees. They're usually practicing medicine as part of a Kaiser or big corporation, and that infrastructure there. In ophthalmology, we tend to serve an older segment of the population, but as our population is getting younger, and in general, younger patients, now we're all connected with our MyChart and Epic, and they expect to be able to send us an email. They often want to schedule themselves without talking to a person. They'll say, I'll be there at 2 p.m. on Thursday, and they don't want to hear the doctor has no openings for the next 6 months. So they want the kind of service they're used to now with Uber or Lyft, and they want to be in charge, and they want to be very much part of the process with the doctor rather than be listening to the doctor talking during a brief exam. So it's hopefully it's a great opportunity. The young doctors, I think, embrace this, and the young patients are really eager to be part of that new way of doing business.
Michael?
Yeah, I don't want to repeat what Peter said. So this is what I mentioned before. It's the new way of interfacing between the doctor and the patient. But let me bring in another aspect that I see coming, and also give you an example. We will see what we call an extension of healthcare providers. We will see other players being part of that ecosystem of healthcare. And just an example, as David mentioned, machine learning. We have about more than 1 million of cases in diabetic retinopathy studied in India, where they were basically pre-selected by an AI system. But the important point is actually we could take the technology out to people managing the data acquisition who were not trained as a medical professional. And this is another effect that I see of the digitalization, because and what I called before, both industrialization as well as democratization of healthcare, because it will provide access to healthcare, or at least a diagnosis, to many more people than we can think of today.
So David and Ashley, building on the patient theme here, how can industry collaborate on this personalized medicine that Peter kind of talked about? David, Ashley?
Well, I think the big idea, sort of following on from what Michael was saying, is what I call stratification of care. As we're listening to Peter's example, you imagine, if you have something that you think as a patient is really pretty common, you just had the flu or something, and the ability to kind of do the lift version of seeing somebody to get the prescription you kind of almost know you need yourself. You work that out. You want that to be in a very rapid, simple, convenient way. Whereas if you have some rare disease, there you're really talking at the other end of the scale of stratification, where you want to get through all the roadblocks as fast as possible and see the true expert in the state of Maryland. It probably will still be somewhat geographic, but just look at cancer treatment these days. More and more you see probably top 10 institutions in this country certainly leading the studies for a lot of the patient trials.
Ashley?
Stratification.
Yeah, I guess what I would build upon is, I guess what we've learned is when there's high consumer engagement, there tends to be really good disruption, innovation, and lower engagement, it's slower. And so, I have always been, quite frankly, stunned at the low engagement of consumers caring about their eyes. And so I think that technology can be our friend to say, get more engaged of the lifetime value of your eyes. And whoever can help us be that horizontal aggregator, if you will, from the time of birth of dealing with myopia and slowing down and disease intervention, the disease progression of myopia, to refractive correction, to dry eye, to a little bit of beauty aesthetics, to the point of cataract or retina or glaucoma. Technology can enable more of that connective experience in families. And we all know when we have a loved one how fragmented care is and how hard it is. And we talk about Epic, but goodness, imagine if you could have traveling Epic on a case. So I think, again, we're at the early days, and I think that a lot of the technology can help really enable a transformation in ophthalmology.
Michael and Ashley, you saw that slide I showed where there's more virtual visits. Do you see that trend accelerating over the next 5 to 10 years, Michael?
I do.
Okay. And what will be the impact from that?
Well, I think I alluded to this already a little bit. I think we will have other. Just give you an example. If you think about an 85-year-old, 86-year-old person in an elderly care home, why does he have to travel? She have to travel to see an ophthalmologist for a regular checkup? This can be done at least for the regular checkups in a virtual visit. I mentioned this case about diabetes progression in India, which is going to become a real big problem in the emerging world, and it's just impossible to manage this by in-person visits. Absolutely impossible. So that's the reason why I believe these virtual visits, however you calculate them, will grow, will rise. And it's not necessarily a bad thing. I know a lot of physicians think this will take away their jobs and will actually alter their jobs. I think this can be of a tremendous help because as David said, it depends on what you want to do. If it's just a regular checkup, so I don't think there's a point to go there. You don't go to a store these days for a lot of things. You buy it online. But then if you really want to have good care, stratified care, as you said, David, I totally concur, then we will have on-site visits, absolutely.
So Ashley, I'm assuming you're going to say yes too. So tell me what the impact is there.
I would concur that I think that there's going to be, it's a good thing, and I agree. I think some of the laws are 50-year-old laws that need to be revisited to enable better patient care. And, I think that, again, many cases, not just in the U.S., but globally, enabling better telemedicine, enabling and augmenting better virtual medicine, I think that's a really good thing for patients. And I don't really view it as replacement. It's very complementary and augmented. So I think the patient wins.
I think a great example on this sort of attacking the discussion from a different angle is connected care. And you can imagine if you can really, obviously, upholding all the security you need to avoid patient data being compromised or stolen or misused. You can imagine the scenario where, sadly, somebody's been in the ICU. The good news is they get discharged to general ward and get sent home. And, go back to Ashley's example of sensors everywhere, right? In equipment, cars, everything, our houses that we use. That patient at home with those monitors, of course, can be monitored, again, initially by a machine. Right. And of course, that informs which ones need to be sifted out and looked at by, a healthcare professional. And then you can imagine it's dead simple to say, sorry, last 3 weeks ago, you're in the ICU. Unfortunately, looking at your vital signs, you're taking a step back. And whether that's a phone call or whether it's an email, I think that's very personal. Probably depends on the age of the patient as well. You should be coming in. What a great way to prevent really bad problems. So this is the different way, stratification this way, connection that way.
So as we wind up, I have a quick question for each of you. Personally, in your roles, how does your job change in the next 5 to 10 years of these factors, Peter?
Well, one thing that we're seeing is in my career, we've gone from the U.S. population has doubled, and we're getting older. And what's happened is the number of ophthalmologists that we're training every year in this country is the same as it was 30 years ago. So what does that mean? They're going to have to do things differently, and things that we're doing now that place a tremendous burden on our healthcare system, like these monthly anti-VEGF injections. We need better approaches. We need much more cost-effective. Same time, the public or politicians are demanding that we bend that cost curve. So I think the monthly anti-VEGF injections have to be replaced by every 6 months, every year. We need not only impressive scientific solutions, but we need very cost-effective solutions, things that meet the needs of our society. Care for more patients without an increase in the number of physicians. There's been no support within Congress to increase funding for training house officers in the United States, but twice in the last few years, there's been a lot of support for slashing the allocation for medical education by up to 25%. So if anything, Washington is looking at how can we reduce the costs of training physicians. So the physicians that we do have need to be doing physician things, and everything that can be put off to artificial intelligence, screening for diabetic retinopathy, doing things that don't require you to be a physician are the things that we need to be shifting. So the trainees we're training now have to be trained to use their expertise in a much more cost-effective way than back in my day, I think.
Okay. Michael, last word. How's your job going to change as chairman?
Actually, I don't think it changes that much. You've got to stay alert, looking out for all good new technologies. Maybe the slight twist I would say is the range is broader. It goes now from sensorics, robotics, and even for device company to biochemicals and bioengineering. So I think the range, and of course digital, so the range has become bigger, but essentially the job stays the same.
So again, totally different perspective. I want to thank them out of their busy schedules. Let's give them a big round of applause. Thank you.